talk of healthcare in India, our country is, it is a mix of great divides and fantastic paradoxes. We have a huge healthcare divide in our country, but suffice it to say that 70% of our population is residing in the rural areas, and more than 75% of our specialized healthcare is available only in the urban areas or semi-urban areas. So you look at the divide, almost 750 million people are bereft of quality secondary and tertiary healthcare. Paradox. At the same time, India has one of the best healthcares, people imparting one of the best healthcares in the world. You find people from all over the world coming to our country for obtaining quality healthcare of the highest order. So there is a wonderful, wonderful opportunity. We have the opportunity of synergy, a marriage between the available technology and healthcare. We have a lot of players who have got onto the bandwagon, utilizing the technology and synergizing it with the core competencies in healthcare. Talking about implementing a successful telemedicine model as far as the tele-ICU is concerned.
Yes, sir. Yes, sir.
So could you kindly tell us something about that?
We talk about certain parameters, certain objectives. For some time we were talking about primary healthcare delivery. Then we talk nowadays a lot about accident, prevention as a primary objective. The next thing which would hit us the hardest is a loss of preventable deaths. This is only a few years ahead when this concept will come up. And sir, I was involved in telemedicine for last 15 years, trying to find ways to make it successful. Along with telemedicine, we at one point of time at Medica were also flying in doctors to various places like Gaya, Cooch Behar, Katihar, etc. The concept theoretically made sense that there is a demand. But even with the demand, you will not succeed. We saw that in telemedicine. Telemedicine as a concept been around for 20-25 years. There is a theoretical, clear-cut proof it is required. But even with telemedicine happening, we have not been able to really make it a mainstream service. The most important issue right now in the business model was what is the bottleneck and what is it that we are trying to replicate. So we talk about technology. Technology is there. Technology has always been there. It is not the bottleneck. It is a great enabler. Where things are going to fall short, you can jump it up with technology. Skills, doctors, everything were in short supply, but what was clearly, what the deliverable was from Medica point of view, was that who will make the decision of what is to be done in the ICU. That's all. There is no other requirement today in the country, but somebody who stands in front of the video and says this patient needs this adjustment in the ventilator. You said there is a paradox in super specialty. The paradox is the design. You will not have super specialty in smaller towns. You don't have the bandwidth. You don't have the doctors. Actually, there are no patients also. Why should I go to a small town and do cardiology? You'll only be limited to the small town. When you stay in the city, everybody comes to the city. So that's okay. That's how Cuba works. They make monoliths and good roads. That's all you need. So we had doctors come in. We had nurses come in. Then I said, I need 2 committed doctors who will do rounds every day, and the systems are in place. So when the 199 miles were met, then the last mile connectivity was the connection with my ICU at the center. Because most of the deaths in our country happen in the ambulances, in the transfer. So what technology can do, it is the initiator. Now 3 more ICUs have come up. Now people want to only open ICU because ICU is going to make you run your business. It is not secondary care. So if you have ICU care and good ambulance service, that's where the country will move in course of time for better health delivery.
I partly don't agree with you when you said that there are no patients in rural areas. Sorry, I beg to disagree, because Once you have quality healthcare reaching the remotest places, the outreaches and the underserved areas in our country, you will find patients crawling out from under the thatched mud roofs and what have you, because it is for want of quality healthcare that you find people not coming up.
Yes, sir.
There's so many difficulties where which people face in reaching up to the point of care.
Exactly. To have these services develop in that point gives access to people who need not travel, say, 500 kilometers, travel 150 kilometers. So what you rightly said, I agree with you. I think I phrased it wrong. I think the super specialist facilities have to be available within 100 kilometers, provided the roads are good.
Please, if you see anything cogent, anything coherent emerging out of the fog that surrounds the healthcare activities in India, could you kindly throw some light on that?
This government is keen to have a digital health ecosystem, and lots of efforts are there. And now, even from the citizens' perspective, they are coming in terms with it and demanding it also at places. Of course, it's still a very long way to go. If you look at it another way, the big hospitals that we see, in fact, actually they are likely to become smaller in size, offer less services rather than more now that is happening. And it is shifting towards home care. The moment you move to home care, it's not that they would have to come to any center for things. Most of the times, even if you look at the big hospitals, the majority of the patients are there for follow-up or for things for which they need not have come to that big hospital at all. And that increases the number of patients, the crowd, and so time per patient reduces and the queue goes on. I mean, that's probably an avoidable problem. Of course, as you said, the trust factor. I think people would say, I'd rather go and get an opinion from AIMS. Why should I go to any lesser place? That is there, but I think with technology, have this various issues of harmonization coming. There are so many standards. That's the good thing about them. But then you need different standards for different purposes. And in the previous panel, we were talking about seamless integration. So we need to have the standards talk to each other. And for that, there are various, like this continuous design guidelines I was referring to. So the Personal Connected Healthcare Alliance, they have some sort of thing, which ITU, WHO, they're actually coming together. So you have to have all the information coming from disparate systems, from the IoT, wearables, at home, right through the intermediary centers to the doctors treating at bigger hospitals or smaller hospitals, like your tele-ICU centers also. Lots of information will be coming, but unless they are understood, sending information is the easy part, but making them meaningful, extracting the information that is needed, that is often a big concern. So I think technology is going there. If you think about interoperability is not just technical. Interoperability also goes beyond that for the systems. And as we have been always talking about it, technology is probably the easiest nut to crack. But when you come to the processes, it's not that easy. And when you come to people, that's the toughest stumbling block. So capacity building, training, retraining, change management. These are the things which I think now people are looking at. But I think we need to give more concerted efforts.
How do you emphasize the provision of quality, compliant, and cost-effective healthcare services in our country in the current scenario?
Basically, in 2010 onwards, what I have seen in my professional life, the CIO position is basically one of the position in organization which take care of the internal matter of the organization and helps the CEO to drive the business. And it always gives a push to the organization so that the micro information and the macro thinking come towards the CEO to take a decision making. And this position is normally gives a big drive to the organization time to time. It changes the policy, it changes the organization, it sets the organization objectives also and go. Many organization, many small startup, because in 2010 onwards, I can see many organizations are coming up with the new ideas, new business. They are MSME, they are startups, and they actually require a kind of a person of this working, but they can't afford it. It's a very costly affair. What I feel, seeing this healthcare activity, an individual who goes to a healthcare center for a service or a care, he must get value of money. Versus, I will not say cost and benefit analysis. Benefit is something for the product we can think of, but in the sense of hospital services, we must think cost and services. So whatever cost we are paying and what terms of services we are getting, we must have some standard. Small example of say TCDC ESR test. Some organization is taking 40 rupees, some organization is taking 400 rupees. What is the reason behind this? I think government must be working on this. I have heard for last 8 years that there is a organization within the government is trying to come up with a some standard pricing for all these services, vis-a-vis whether it is done automatic, semi-automatic or manual, because TCDC doing manual is hardly a 10 rupees cost, but doing with the automatic or semi-automatic, the cost is different. Or maybe if you have in a granite core based infra, then your cost is different. So somewhere some formula has to come up. So in the individual as a customer or as an individual can understand that this is the price what I am paying is justified and verified by the organization. And then people can feel comfortable that yes, this is what service I have got, and the prices which I have got given to the system in a very pertinent way. So in that way we can have many other services in the healthcare can come up with some level of costing and those formulas.
Well had initially mentioned in his opening remarks about the number of people in India who do not have either any access or have inadequate access to appropriate primary care, and that leads to a massive social inequity and social burden to the extent that almost 39 million people fall below poverty line every year due to health-related expenses, and they have to make these expenses for advanced secondary and tertiary treatment because their urinary tract infections were not treated in the rural areas where they live. So lack of primary care contributes to the disease burden. And just to make it very clear that it's not a problem that's in India only, it is a global problem. And there are about 100 million people worldwide who every day has to compromise between either buying medicine or buy food. In fact, end of October, I'll be in Mexico at the invitation of Mexican government to discuss how to implement a nationwide primary healthcare model. So, there's a problem that needs to be addressed. And I think the three main bottlenecks are doctors, healthcare technologies, and the regulatory framework around the doctors and the healthcare technologies, particularly in the rural areas, in the context of the digital health program, in the context of EHR operability. We all know what the doctor's problems are. There is absolute shortage, there is maldistribution, there is lack of functioning infrastructure. They may be there statistically, but more than 50% of the rural health infrastructure does not function. And then there is relative unwillingness on the part of the doctors to relocate to the rural areas, considering career choices, considering family circumstances, all of that, which is why I call it relative unwillingness. In terms of the conventional diagnostic technologies and therapeutic technologies that we use, which today is an essential part even for primary care, their cost, the skill levels of technicians that you need to operate the conventional modern diagnostic technologies, the climatic conditions that you need to create for those technologies to operate, the supply chain system which is totally disrupted in the last mile, the consumable storage conditions, the disposable conditions, and their maintenance costs. Technicians and engineers do not want to travel to villages to repair an equipment that does not work. And therefore, so many good-hearted people donate so many expensive instruments which lie idle after about a year or year and a half of usage. Because free things don't last. And we have worked out a model whereby if we see between 12 and 13 patients per day, which is a very small number, and charge, say, about 75 rupees for an ECG or 50 rupees for a consultation, including the corporate central cost, the model achieves consolidated break-even. It achieves unit level break-even at about 9 patients a day, and it operates corporate level break-even at about 13 to 15 patients per day. The questions that remain, however, is Although there is an NDHA 2017, the policy document falls short. It's a good mission statement, it's a good aspirational document, but that document falls short of the dots and the strokes of the I's and the T's in terms of what specific regulatory policies will govern an EHR-based medical consultation, so that, because operations below the radar will not last, will not scale, will not replicate. It has to be on the radar. We do not have specific guidelines regarding that.
How do you envisage the synergy between technology and quality compliance for provision of effective home and remote healthcare, of course, with an accent on technology, naturally?
But there, the technology has to make the so-called remote consultation look similar to a in-person consultation. Now, so that's one of the challenge still we have, because of either is a technology limitation or in the communication bandwidth or the way we are using the technology. Today's world has not seen as similar in-person consultations to a tele-consultation. So that's one of the area, because the other point is also the people don't value today the health or tele-consultation or any telehealth services as people would appreciate the services being provided by the doctor in-person discussions. That's also another perceptive problem that we have, because similar to this is the pricing. For an in-person consultation, the people would be happy to pay whatever, let's say 500 rupees. The similar consultation probably is taking a little longer for a tele situations where there is not a face-to-face conversation, but the people would expect to pay much lesser, where it should be other way. But the perception today is, I'm just making a call to someone and he's just telling me something, and even he's not seeing me, but why should I pay him the equal money if I come to see him? But from a hospital or a doctor perspective, they are probably spending more time, and time equal to money, and then spending a lot of investment in the making that consultation happening. But there is a definitely one challenges over there about that money, and the insurance company, etc., they don't even pay for those kind of services. The third point is about how we are using the trained manpower to make this tele consultation, either it's a home health perspective, it's a wellness perspective, or it's a remote working, like what Soumitra was suggesting about a EICU, work in a completely seamless manner. Because a lot of cases we have seen the instrument equipment are in place, but the way it works in a single location, it does not work in the similar manner in a multi-location situation, because at the day in the patient's life value is similar. For him, whether he is treating the patients in Kolkata hospital or maybe an extension center of ICU in a Bhagalpur, the quality needs to be absolutely equal, and then only it will be successful. We cannot take chances as saying that, oh, if you would have come to Kolkata, the outcome could have been better. Now, if that's the statement, it will not work. The outcome has to be absolutely similar, irrespective of the physical location of the patient. Whether the patient physically is located in Bhagalpur or in Kolkata, the outcome has to be absolutely similar, and the doctor has to be equally comfortable in providing treatment to the patients when he is not able to see the way he would have seen the patients over here. So a combination of some amount of technology assistance available who would make the difference and provide all the information for the senior consultant who is actually guiding the person in Bhagalpur is very important. Sometimes we just left it on the technology. Only living and depending on the technology may not work here. We need to have that human factor available there, who is making the information available to the senior consultant, who is adjusting the dose to save life. So sir, these are the 2-3.
Just to add on Partha, you rightly said it's an inefficient system. So as somebody had mentioned earlier, that we have to enable the doctor spend least amount of time, because these consultations are longer period, and they have to be charged. So I tried this thing out with 2 centers. In Tripura, I charge for first I get the best doctor. I'm not giving my middle-level doctor. I give my best doctors and I charge 2,000 rupees per consult. And there are no walk-ins allowed. all by pre-appointment based on a fixed schedule. It worked. But you have to give in your papers one day before. It will be analyzed by the department, kept on Dr. Pahadi's table. He'll see you the next day at the given time. Telemedicine this way has worked, although previous my models didn't work. So I just wanted to add to that. It has to be done in a more organized way. Doctor has to spend the least time possible. You need to assist him with 2-3 other assistants. A backup department has to be. Now telehealth has to be a department by itself and to work with all the doctors in the hospital. Maybe that is a better way forward.
We combine technology with services of this kind. There is a whole lot of data that is generated. And you all must be very aware about, there's a lot of hue and cry about privacy and security of data, because I would like, there was just anecdote I want to tell you. I remember reading somewhere that, you know, there is a lot of hacking going on and stealing of data. I remember reading a report that in the US, if somebody sells data of a credit card, it costs the buyer around $5. But if they sell the data of a health card, it costs around $25 to $30. So you can imagine what is the importance of security of data as far as healthcare services is concerned, because a whole lot of activities which are associated with the entire gamut of, entire paradigm of healthcare. So I would like Rahul, who's a security expert from, and you've already seen him earlier speaking on the podium. Rahul, would you like to throw some light on the security aspects and what to do as far as security is concerned about healthcare data?
Everything is available on telephone, on internet, as well as a video call, right? Now, somewhere or the other, we all understand we are digitally transforming, which of course means that there is an intense and relevant usage of internet in between. And as long as there is internet in between and there is data traveling, yes, there is a risk. And very well said by you as well, sir, that health data is definitely one of the most expensive data which is available globally right now. Okay? So it's very important while we are talking about taking relevant steps towards digitizing the kind of treatments and the processes that we have in hospitals and healthcare today. It also puts a lot of focus on ensuring that we have preventive security solutions before or along with when we design these solutions in terms of digitizing, whether it is tele-ICU or it is telemedicine or it is doing video calls or doing, giving these prescriptions and all of that. Because we got to one or the other day start storing data. If we are not doing today, historically I'm not too sure how good have we really done as a country in healthcare, but then if we have to start someday, we got to store data for a longer period of time. Storing it and also securing it so that we can of course deliver much better solutions, much better treatments and cures and these kind of concepts in future for the generations which are about to come, right? Now for that aspect it is important. I'll take a use case scenario and I'll be very brief. Today we're talking about, let's say somebody, a doctor, a senior doctor with his team and everybody connecting over an internet, delivering whatever services or that suggestions given, right? How do we do that? We of course are using various different devices, okay? At times we connect over internet. How do we make that connection? Important piece, accessibility, connectivity, and the kind of devices that we use, right? All of this is very important that we know that the connectivity that we are using to make this access possible has to be secure. There are multiple security solutions which work on the connectivity side only to ensure that this internet connectivity between the patient and the doctor is secure, so that any data transferring on this line, on this connectivity is secure, number one. Number two, you mentioned very rightly that, for example, best of the doctors aligned, charge 2,000 rupees, reports or the documents to be sent a day prior, right? Documents sent a day prior on email most probably or any other medium, maybe scan, uploading on a link, email, whatever, right? Sending it one day prior, it gives about good 7, 8, 10 hours for the people on the other side, possibly, I'm not saying that's the case here, but then possibly to do whatever they want to do with that data, which is being communicated from one end to the other end of the world for a discussion tomorrow. right? Any modification, any alteration, any change to that slightest of the document or the information can make a huge change to somebody's life. Hence, there are solutions available which can be worked at the device level, at the internet connectivity level, and the remote session level as well, which can make this connectivity very secure. And hence, it can always add a lot of value to make these solutions more relevant and more accessible and more secure in future as well. So that's what companies like SonicWall can always help and kind of work around with people like you.
So, where are we heading? Dr. Sarbadikari, if you could throw some light onto this.
If we look at, not just telehealth, health IT overall, digital health, anything, the most important thing at the top is really standards. So that makes seamless integration possible, that gives the value addition. The next is, of course, the legal or regulatory framework. That I think we are still to go there, because as I said, the National Health Policy had recommended the setting up of the National Digital Health Authority, but that is yet to be done. The other part is, of course, education training, capacity building, change management, that's where. So these are the three pillars. So if you look at it, I think the regulatory we are waiting for, but even if the regulatory doesn't come, just as it happened in mobile technology, the market is going to take care of itself. There is a demand, user demand for telehealth. So telehealth, especially moving towards telehome care, is already there. There are already some companies in India which are practicing it, and it's going to definitely grow over time. So I am optimistic, and I think very soon we'll have also the necessary regulatory guidelines in place.
Thank you, Professor Sarbadikari. Telemedicine Society of India, of which I am a member, I was a part of the venture. We have recently drafted a white paper on TeleHealth Act as it pertains to the healthcare activities, telehealth activities in India. We have submitted it around 2.5 months back to the Niti Aayog. They are deliberating upon it. Probably the next week or within the next fortnight, we will be submitting it also to the Secretary Health. Mrs. Preeti Sudan was kind enough to ask me personally to hand it over to her, because this time period, this is a very crucial time, because the NDHB also has to take effect, and it has to be publicized in the near future. So probably we'll see something emerging out as far as the regulatory mechanism for telehealth activities is also concerned.